Hi guys, so this is the third and the last talk about the emergency management of asthma and COPD. So the way we are going to approach this talk is we'll go through with how we manage an acute asthma attack in adult patients, and then followed by pediatrics, and then we'll discuss the acute exacerbation of COPD and how do we manage it. So it's really important for all of you to understand that despite all the effort that we are putting in asthma management, asthma is a source of mortality in children especially. It is unfortunate, but I think the biggest problem within the management of asthma has been published recently in Lancet and other journals, is the poor understanding of the severity of how quickly asthma can get worsen in kids, and how quickly it can turn into a medical emergency, and then cyanosis and ultimately respiratory failure. The important message here is that we need to have a timely recognition of asthma, as well as we should have a good understanding of how we can measure the deterioration of asthma in a given patient. As such, if you look at the way we manage asthma in acutely ill asthmatic patient, the initial assessment is the best thing we can do. So, excuse me, the way we acutely assess patient is when they are presenting to us, what is their situation. Now, nobody present to a healthcare professional without doing something about it, unless like they have no access to medicines or something like that. So if they're stuck in a place where they don't have any healer, then obviously they won't have anything with them and they haven't done anything. But if they're coming from home and their usual place of residence, then they must have some treatment being given to them. So it is really important that first of all, we will like to find out that are there any alarming signs and symptoms. So instead of just looking at this moderate acute asthma, you should look at the actual severity classification. So you should look at the acute, severe asthma and life-threatening asthma to see none of these things are available. For example, if in a given patient they cannot perform 50% of their best predictive value, excuse me, then it's a clear sign that their asthma is worsening. Now, just to cite a very good example, as you may have noticed from last night presentation as well, that I am struggling with my asthma at the moment. But when I look at where I am in moderately acute asthma situation at the moment, because I can see that although my symptoms are increasing, I do not have my respiratory rate above 25. I'm not tachycardic. I'm able to record this presentation, obviously, so I'm able to complete sentence in one breath. Although I'm struggling with it, but I can still do that. So it is really important that we are able to separate acute severe asthma. Life-threatening asthma, you probably don't need to separate it because it will be quite obvious. It will be physically demonstrating, the patient will be physically showing with the sign of the life-threatening or near-fatal asthma. So it's basically the confusion between acute severe asthma and moderate acute asthma that people really underestimate. So it's important that we look at their PEF value. Most places have a peak flow meter in their drawers of emergency or office, so you can quickly put a plastic cap or a disposable cap on it and ask patient to blow in the device. And although you don't have the best value for most of the patients, just look at the chart, and if it is less than 50% of the predictive value, then obviously you just put them through the acute severe asthma pathway. and we'll discuss what that pathway is. But what we will do now is first we'll just briefly cover what is the moderate acute asthma treatment look like. So, excuse me, if you are having a patient with moderate to acute asthma, you need to double up their preventer. So if they are on inhaled corticosteroid, you need to add inhaled corticosteroid with a LABA. You need to double up the dose if there is no LABA option available. You need to make sure that they are getting 40 milligram of prednisolone daily for 5 days at least. So that's the treatment. And once they get the first dose of prednisolone 40 milligram, they get about 6 to 8 puffs of their Ventolin. They get double the dose of their ICS. And if you monitor them for up to an hour, you will see that most of them are responding very well. So they are coming out of that acute attack. If they are, you need to monitor them for another hour at least. And after 2 to 3 hours, if they are doing fine, you discharge them home with clear directions and how they can monitor themselves. If there is any signs of acute or severe asthma, they come back to you. Now, acute and severe asthma as well as the life-threatening asthma. Once you know these patients, like you have screened them quickly to see yes, they are unable to complete their sentence. Their best predictive value of peak flow is less than 50%. You quickly look at their breathlessness and their tachypnea, tachycardia. You document that. You quickly check their oxygen saturation. If it is less than 94, you give them supplemental oxygen. Try to make sure that their oxygen is between 94 to 98, ideally 98. But in any case, it has to be above 92 because going below 92, it means they are severely deteriorating. If they are not maintaining their oxygen saturation, you also like to do their arterial blood gas because you need to know whether they are likely to go into respiratory failure and needing artificial intubation or artificial ventilation. You also need to not look at the chest x-ray or order a chest x-ray unless your patient is having some evidence of pneumothorax, some sort of suspected consolidation pneumonia. If their arterial blood gas is really bad and they are requiring ventilation, you need to see if there is any physical obstruction or not. So it is really important that we do that. Now, anybody who is not having a moderate asthma attack, they need to be admitted either to emergency department or to the hospital. And then you need to keep assessing their severity, and you need to make sure that their peak flow is either close to 75 or definitely more than 50% after the 1 hour of their treatment. So sometime what will happen there, you'll find somebody who's going into severe asthma attack, but they are not there yet. They are not like a moderate asthma attack, and you start giving them treatment. And if they can go back to moderate asthma and they are progressing well, then you can discharge them as well, because you don't want to risk an hospitalized infection, or you don't want to really expose them to all those more severe asthma treatment at this stage. So the people who will be given steroid, they did well after using salbutamol puffs, after using their preventer, they go home. People who stay, in those patients, you need to give them oxygen. You need to make sure that the steroid treatment is started as soon as possible. And you need to make sure that you start the nebulized salbutamol, because in most cases you probably need to give continuous salbutamol to these patients. So intravenous salbutamol have a lot of side effects. It's quite dangerous drug. You need telemetry. You need to be in acute care area. So usually, and there's no added advantage, so you can simply give them inhaled beta agonist. Inhale and nebulizers are pretty normal. or they are quite comparable in terms of efficacy. But sometime in severe asthma patients, they have some chest tightness, they have some sputums, and it kind of give them a much pleasant feeling of getting a nebulized salbutamol with oxygen. Is also quite practical. You don't need to stand in front of patient. You can put the 5 milligram or 2.5 milligram, depending on the protocol, into your nebulizer, and you can give it with humidified oxygen. It basically help them breathe more easily, and that's why we try that. If they cannot get 40 to 50 milligram oral because they are unable to swallow, they cannot really do that. So you can give them IV hydrocortisone. The importance is that they need to get corticosteroid systematic in their body as soon as possible. Patients who are not really responding well to beta 2 agonist, there we use them either magnesium sulfate IV as well as ipratropium bromide. So we give them atrovent, which is like SAMA. We mix that with beta agonist and we give them 0.5 milligram. It's not usually continuous because it's a longer acting compared to SAMA. Compared to SABA or Ventolin. So we give them less frequently, maximum every 4 hourly, or more traditionally 4 times a day, every 6 hourly. Now, most of these patients will respond well with this. If they are not responding well, and you measure them every 60 minutes, and if they're deteriorating quite rapidly, you refer them to ICU, and then most of these patients need to be ventilated and then managed accordingly. So this is how we deal with acute asthma attack in adult patients. If you are counseling somebody in your primary care, everybody should have some direction of that. If they are having an acute asthma attack, then they should sit down, take their 2 puffs of Ventolin, give themselves another minute or 2, then take 2 puffs of Ventolin, give them another minute or 2. In summary, between 15 to 20 minutes, within half an hour, people should have at least 3 to 5 doses of their salbutamol. And then after taking 3 doses of their salbutamol, they are not getting any benefit, or they are not getting any reversal of their shortness of breath, they should call the ambulance while waiting and taking another 2 doses. So more than 5 doses of salbutamol, there's no harm, you keep using it, but more than 5 proper doses of salbutamol not helping you, you need systemic corticosteroid rescue treatment as soon as possible. So it is really important that we pass on this message to patients who are being managed at home. Adult patients, they should know how to assess they're getting worse, how to assess more objectively, and how to act on it. Patients who are having more than one acute attack, for example, someone like me, within a month, if I'm having a second attack, then it's important that I should go and see a specialized respiratory nurse, pharmacist, or a doctor who is managing asthma patients more frequently and who are looking at asthma patients who are more complicated than an average asthma patient, so that we can explore that, is this the best way, am I doing the best possible care of my asthma, or do I need some additional help? By the way, I've been booked next week, so I'll be seeing a respiratory specialist just to review my asthma and what I'm doing wrong. So in children, acute, severe, and life-threatening, we don't have that moderate kind of category in kids. The reason we don't have that moderate kind of categories in kids is because it's really difficult to pick up that early. So usually it's that the parents who are going to notice it, and that moderate kind of activity where you still have 50 or more than 50% of your PEF, best predictive expiratory peak flow values, is very hard. for somebody else to assess it. Usually parents notice when kids are either breathing very fast, or they are unable to talk, or they are crying a lot, they are stopping to get their milk, or they are not feeding well, because feeding might also reduce their ability to breathe in, and that's why they find it very hard to feed, like to get their feet. And these are the signs. So acute severe asthma or life-threatening asthma in kids, we take them to the healthcare professional, and as a carer, they must have been counseled before. If it is the first time, then they are usually being counseled that they can give up to 10 puffs of salbutamol via MD and spacer. And if after that there is no benefit, then we should do something about it. So it's basically same thing that 2 times 5 is 10, so 5 doses of salbutamol. But it's important to understand that in kids sometimes it's a bit harder to administer it, especially if they are young. So the whole trick is that you just keep them still, put the mask in, and try your best to give 2 doses each time through spacers, and wait, like the 1 puff every 30 to 60 seconds sometimes may not work as well. But what you need to do is give them some breather, give them some space so that they can cry a little bit, and then you can put the mask back. Make sure that you are trying your best to give 1 puff every minute. Now that 1 puff giving practically can be quite difficult, and that's why it says every 30 to 60 seconds. So basically you give 1 puff, you try to hold the baby as much as you can, maybe 10 seconds, 15 seconds, and because the inhaler and mask is able to vent out the expired air into it, it's not going to suffocate the baby. So if parents have this feeling that it's going to suffocate their baby, it's not possible, because you can breathe in from the spacer and you can exhale out from the side vents of the spacer. So it's not that the mask is going to suffocate them. So they give that 10 puffs and there is no benefit, so they are definitely calling help. So ambulance is on its way. While they are waiting, they can keep doing additional doses of bronchodilator because it's important. So that's the only thing they have. When paramedics usually arrive, it's important to start nebulizer, because nebulizer will again give them that same humidified oxygen, and it's going to make it a bit less dry. Most of the kids often have coexisting viral diseases which cause even more discomfort because of the dryness. Now, the treatment of asthma in the acute asthma in adult and children is not that difficult, not different, except that we keep using the PMDI in a spacer, just like in adult patients. We give them ipratropium bromide, but we are going to halve the dose. So most of the time, if you are giving 5 milligram to adult salbutamol, you give 2.5 milligram to kids. If you are giving 500 microgram to atrovent to adult, you give 250 microgram. Other than that, I don't think that there is much difference, because magnesium sulfate is very nasty on veins. That's why we don't give them IV magnesium sulfate. We like to give them nebulized magnesium sulfate with salbutamol and ipratropium in patients who are not responding well, still have saturation of less than 92 despite getting the treatment. Also, if patients, kids are on longer acting beta agonists, we try to stop that, because we will be using a lot of short acting beta agonists and it can cause tachycardia, can be a big problem. Another important thing that you should remember in kids is that the steroid is not basically 40. You look at 10 milligram of prednisolone for children under 2 years of age, 20 for children 2 to 5, and 30 to 40 in children more than 5. If you really want to not remember all of that, I think the easiest way to do is you do 1 mg per kg or 2 mg per kg per dose. We don't give more than 60 milligram. In practice, you don't give them more than 40 milligram anyway. And if children are unable to hold it, they're vomiting, because of a lot of the time when kids cough and try to expel sputum, sometimes they also vomit. So if prednisolone is not being absorbed, obviously you repeat the dose, or you just give them injection intravenous corticosteroid. Again, corticosteroids are important. Less than 2, 10 milligram, 2 to 5, 20, more than 5, 40. So easiest way to remember is to 10 milligram for 2 years old. If they are double the age, you double the dose. So instead of 10 milligram, you give 20 milligram. So double the age is up to 4, 2 to 5. And then if they are more than 5-year-old, you give them 30 to 40 milligram. If it is a bit difficult, give them 1 mg per kg per dose. Those who are on chronic steroid treatment, you give them double, so 2 mg per kg up to 60 milligram. Usually we don't use it for more than 5 to 7 days, but even in severe cases where you end up using up to 10 days or 14 days, you don't have to taper it if you stop the prednisolone within the 14 days of the start. Second line treatment for asthma, again, is not really important at this point, because we won't be dealing with those patients. But you can use injection salbutamol, you can use intravenous magnesium sulfate. Although it's very difficult to give, it's quite unpleasant, but if they are not responding, then obviously we need to do something about it. So adequate planning and follow-up is important with acute asthma. So it's important. Difficult to treat asthma we are not going to discuss, because difficult to treat asthma has a lot of other complications associated with it. Quickly, we can look into the management of acute exacerbation of COPD. So, COPD acute exacerbation. Patients of COPD usually have baseline symptoms and baseline condition that they are used to it, and every now and then they have increasing cough, increasing sputum, increasing shortness of breath, and those kind of situations where there's bad days are often classified as acute exacerbation of COPD. The slight difference between having a bad day on COPD versus having an acute exacerbation, usually you feel generally more ill, and it is often coexisting with some sort of flu or other infections, and that's why it's been treated differently. Most of the COPD exacerbations are infectious, either viral or bacterial. So apart from giving 50 milligram or equivalent of prednisolone in these patients, we also give them antibiotics, especially if there is an increase in sputum volume as well as the viscosity. The color of sputum has been shown to be very unreliable indicator. So if they have a brown color or a red color or a pink color, we don't give them antibiotic just because of that. It has increase in the volume as well as the viscosity, thickness of the sputum. Again, just like asthma, increased use of short-term bronchodilator, we use oxygen, mucolytic, physiotherapy, chest repercussion, so that they are able to expel the sputum. Most of the time, we need to make sure that when these patients are having an acute exacerbation, we quickly check their vaccination record, and if they are not getting their pneumococcal as well as their influenza vaccine, this is an opportunity where we vaccinate them, so we eliminate the most common cause of COPD exacerbation, that is viral illness as well as bacterial. I suppose these three management strategies should be enough for you guys. So management of acute asthma in children and adult population, as well as the management of acute exacerbation of COPD. Again, I apologize for the voice problem in the previous slides. And I think I find this particular piecemeal approach much better. So I think from next year on, I'll probably try and make these videos even more shorter pre-lecture, and then we can have more discussion in lectures, so that it's more better learning experience for all of you. Again, thank you very much for your attention, and I wish you all the best for your final exam.